took place. We were at the Ferrante Room at the top of the Marriott Monterey. Bruce Taylor of Taylor Farms was our speaker, and he gave us a superb overview of his career in agriculture and the building of his company, Taylor Farms. About 100 people were in attendance, sitting together around the table, eating a delicious breakfast. In 5 months, 150 days since then, the world has changed. We learned new words like social distancing, how to wear facial covering. The economies of the world have been transformed since March of 2020. Some economies have collapsed. Travel has been severely affected. Locally, our major economic driver, hospitality, has been wounded. Major events have been canceled, like the Concours d'Elegance, Monterey County Fair, historical races at Laguna Seca, or the Jazz Festival. Some hotels are closed. Some restaurants are closed. Some will never reopen. Small businesses are particularly vulnerable, the sole proprietors or the very small entities that provide the necessary canvas to support the local economy. We learned very quickly about new words like the CARES Act, Zoom, or again, the PPP. We witnessed also how the federal government injected trillions of dollars in the system. And I don't know about you, but I still don't know how many zeros we have in a trillion. Anyway, the bottom line is that many people lost their job, lost their dreams, lost their businesses, maybe lost their savings. And the future looks very fragile. All of this in 5 months. Today, your chamber is holding a virtual CEO breakfast with all the technical difficulties that you've just witnessed. It's the first of its kind. Thank you for your patience. There's no gathering around the table, no hot coffee or delicious pastries, but the purpose remains the same. We want to inform you by bringing you one of those exceptional executives who will discuss the evolutions taken in this industry. We did not hesitate one instant in the selection of Dr. Packer, CEO of Montage Health, as the best speaker to bring you today. This will be a webinar, another new word to some, but you will be able to write your questions by clicking on the Q&A box at the bottom of your screen. At the end of the presentation, your speaker will devote the time necessary to cover those questions. The webinar will be recorded and a link will be sent to all participants. We're very grateful to welcome our presenting sponsor to this breakfast service, First Capital Bank, our community bank. Let's start with a PowerPoint presentation now. Richard, we can start with the PowerPoint presentation. Maybe there is another difficulty coming up. Okay. Very pleased to see that the quarterly CEO breakfast is getting underway according to the plan, minus 15 minutes. Sorry about that. We want to thank you, our sponsors, particularly First Capital Bank, our presenting sponsor, and then also the additional sponsor, Pacific Valley Bank, and also Glastonbury. Glastonbury is behind the scenes here dealing with the internet connection that disappeared magically a few minutes ago. We also have, as additional event sponsors, of course, Montage Health, Brain Technology Solutions, eLab Communication, Marketing Springboard. In addition to that, Post Weekly, Monterey Signs, and Geisler 3. Then other sponsors will be, if you can go on to Silicon Pictures. Silicon Pictures is a very interesting company. Last year, this new member introduced himself to the chamber and to the community. Carl Miller is his name. He visited us and he revealed that he spent his career as a director of photography for an industry icon named George Lucas. He had now relocated to the peninsula and started his own business. And we worked on producing a short video for the Chamber of Commerce. So we salute Carl for, as a consummate professional that he is. And we're very, very pleased to show you a sample of his work with this video. So ready for that. When you're ready, show the video, please, Richard.
My name is Sean Adams. I'm the owner of Monterey Signs. Internally, we say we like to hit a base hit with our customers and not necessarily a home run. And therefore, we earn their repeat business over time. For the first 6 or 7 years, we doubled our business every single year. I would highly recommend joining the Chamber of Commerce because it's a great opportunity to grow your business and get to know other people in the business community.
My name is Corazon Escarraga, and I am the owner of Escarraga Luxury Cleaning in Monterey. Integrity for me is very important. Seeing like the different level that I can do, just like not only like residential, but also working for companies. So, and that's what it was like. So it started growing and growing in.
My name's Ted Balisberry, and I'm founder and chairman and CEO of the Cannery Road Company and Cannery Road Management, which is a parent company over various related companies. You want to invest in something that's going to invest in all of us to make Monterey a lot healthier. When time goes by and you enjoy what you're doing, you'll always be successful. If you're serious about doing business in Monterey County, I strongly suggest you join the Monterey Peninsula Chamber of Commerce right now. Congratulations.
Thank you so much.
All the best. Congratulations. Thank you very much.
Congratulations. Thank you.
Thank you again, Carl. Repeating our mission statement, the mission, of course, is to support member success and promote the regional economy. Briefly, we are a 501c6 business association, and we depend on dues, events, sponsorship, and grants as our only source of income. So because of the difficulties we've had, I don't want to take more time to prevent the speaker to go over his presentation. So I just want to say this in closing here. I want to thank particularly Clay Larson, who is the regional president of First Capital Bank, director of client relations, And he could not be here today. He is suffering from some ailment, but would like to recognize him and then also his sponsorship in the First Capital Bank. So we have a very, very short announcement, and then I'll pass it over to our board chair, Aaron Waters. Go ahead, Richard.
COVID-19 is rising in Monterey County at an alarming rate. It's serious and it affects everyone. But there's one simple thing we can all do to make a difference. Wear a mask. Wearing a mask can save your life, and your friend's life, and your neighbor's life. It might even save a stranger's life. Wear a mask for you. Wear a mask for all of us. Brought to you by the hospitals of Monterey County.
Thank you very much. I'm going to pass it over to our chair, board chair for 2021, Aaron Waters, with Rain Technology Solutions. Go ahead, Aaron.
All right, thank you, Frank. Again, I want to say thank you again to First Capital Bank and their support of this great series of the CEO Quarterly Breakfast, helping bring all of us exclusive content to you from our most prominent local business leaders. We do recognize a few board members that are with us this morning, this very early and crisp morning, including Clarissa Lowe, Eileen Groves, Alex Winkle, Jackie Atchison, and Phyllis Grillo. And to those who have joined us, thank you as well. And thank the whole board for their time and participation through all this. It's been really, challenging, but also an interesting experience to work with everybody. And just want to thank everybody here for attending the CEO Quarterly Breakfast event. There will be some very relevant and crucial discussions around how this pandemic is affecting all of us locally. And we appreciate Dr. Stephen Packer for taking the time to speak with us today. So without any further ado, I'd like to introduce CEO of Montage Health, Dr. Stephen Packer.
Well, thank you so much. And it looks like you can see me, which is great. Well, good morning, everyone. Again, thanks for all of you who've taken the time to stay on. We apologize for the technical difficulties. I think we've all probably struggled with Zoom at one point or another during the pandemic, and it's yet another new skill I think we've all developed. I want to thank Frank Geiser for inviting me, and I want to thank First Capital for being the premier sponsor for today's breakfast. I think what I'd like to share with you is our perspective on what has been an unprecedented health crisis. It's been a journey of determination and of compassion, and it really has reinforced our commitment to serving our community and really addressing the needs of our community. This morning, in the next 30-35 minutes or so, want to go through these topics. I want to go through a timeline of the pandemic. I want to talk about some of the numbers of COVID in the county and at CHOMP. I want to spend some time talking about testing, which has been a source of, I think, frustration and confusion among many people in our community. I want to touch on therapies. I want to talk about how we may be able to help your businesses, and I also want to talk how you can help us. I want to acknowledge some of the graphics that we're using during this morning's talk. These graphics were put together as part of a monograph that our communications and marketing team produced really for our community and for our supporters, called Inside the Pandemic. And I find them really striking, so I'm really pleased to bring them and share them with you this morning in this morning's talk as well. This particular image was taken in April in our triage tent that went up in March. This is a tent that was established specifically for us to isolate patients with respiratory symptoms who are presenting to our emergency room, prevent them from really interacting with the rest of our emergency room population, and in a safe, open air way be able to obtain testing and do our initial assessment and determine if those patients needed to be admitted to the hospital or safely discharged home. This is essentially the timeline for the pandemic, and it's pretty striking. In many ways, it seems like we've been dealing with this for years, and I know for many businesses, it seems like an eternity since you've been able to fully operate and open for business. And in many ways, it's really quite remarkable and shocking that it's really been 5, and we're entering now our 6th month of the pandemic in earnest here on the peninsula. Hard to believe that the first case was described literally in December of 2019, hence COVID-19. And then our first case confirmed in the United States was in late January, first case in California, in the Bay Area, January 26th, first documented death, February 6th. I think some of those early numbers, we're starting to get a sense that the virus was here considerably earlier than that. We didn't, if you don't look for it, you don't see it. And testing wasn't widely available. But our sense of epidemiologists going back is certainly sometime in fourth quarter 2019, the virus had already taken a foothold in areas of the United States. In early March, the county activated its emergency operations center, and in fact, in early March, we stood up our hospital incident command, a daily meeting of team members from everything from supply chain to our clinical leaders, our infection control leadership, and so on and so forth, really to develop a coordinated and evolving response to the pandemic. On March 30th, we experienced our first death in Monterey County. To date, we're up to 34 deaths in Monterey County as a result of the pandemic. And I'm going to apologize in advance. Some of the numbers that you're going to see today, and there's a lot of numbers, they change on a daily basis. So hopefully what I can give you is a sense of proportion and some walking around numbers a little later on that give you a sense of how these different numbers relate to each other. Our hospitalizations really, and we'll talk in the next slide about what happened to hospitalizations here at CHOMP. You'll recall that on May 30th, the county, we went back to a reopening under the governor's plan to phase 2.5. Unfortunately, some of that's been rolled back since. And then our hospitalizations really started to increase again on June 20th. And then on July 2nd, we were put on the state's watch list as one of several counties throughout the state. And that has implications, obviously, as it relates to school openings and the like. So this is a snapshot from one of about a 5-page daily dashboard, daily status report that our COVID task force here at Community Hospital publishes every day for our in-house use. It tells us how many persons under investigation are in the house, how many positives we have in the house, COVID positives. Today or yesterday, we had 9 COVID positive patients in the house. And if you look at sort of, this is a list or a graphic display of how many patients, PYs or positive patients we had in the hospital. There was March, in first few weeks in April, we had a real hump. And it's a little bit like a camel. We've had 2 humps where we had a period of really amazing quiescence with essentially no cases in for a period of about 6 weeks. 2 things happened. We had a Memorial Day weekend. We had a reopening phase 2.5. And then we started to see, as is typically the case, about 2 to 3 weeks later, an increase in hospitalizations. Our maximum hospitalization here at Community Hospital on any given day has been 15. And we've had about 70 hospitalizations here at Community Hospital for COVID positive patients. The county reports a number of hospitalizations on their daily dashboard that many of you see either directly or maybe through the Pinecone or through the Coast Weekly or the Monterey County Herald. The number of hospitalizations that have been reported in the county it has been, as an artifact of how they counted, has been underreported. If you were to go to the county site today, you'd see about 295 total hospitalizations in the county. Hospital officials estimate that number is around 460 to 470 hospitalizations. How does that happen? How do we miss those? Well, if I'm working at the county and I see that, well, CHOMP had two hospitalizations here, and then went to 4 hospitalizations, I'm going to assume that there were 2 more people hospitalized. Well, I may have discharged 1 and admitted 3. And that happens a lot, so that you can't simply look at a graphic like this and say, well, what's been the change from yesterday to today? Oh, it's changed by one, i.e. one more admission. In fact, that's not the case. It could have been 2 or 3 more admissions if we likewise discharged an offsetting number. So let's go look at some of the numbers. Just a quick comment. In our patient-facing areas, our staff wear surgical masks, and we'll talk about different kinds of masks, N95 and the like, for higher risk areas, and eye coverings. Those are, for us, the 2 most important pieces of PPE, much more important, frankly, than gowns, booties, hair covering. It's really aerosolization that we're concerned about can be absorbed through mucous membranes, hence the eye covering, as well as the masks that cover the nose and the mouth. All right, so here's just, as we're going to talk about, we're going to go through about 3 or 4 slides on numbers. Let's just see what we can derive from this particular snapshot. This is as of August 4th, which was, I guess, yesterday. We will surpass 50,000 tests in Monterey County today. We will surpass 6,000 tests at community hospital probably tomorrow, and we will surpass 5,000 positive tests in Monterey County for a testing positivity rate of 10% at the county. At community hospital, we have a testing positivity rate. It varies day by day and sort of what part of, what week or month we're in. Overall, over the course of the entire pandemic, we're coming in at around 4%. Obviously, the hospitals in Salinas have a higher test positivity rate. They're seeing more patients, and they're seeing more symptomatic patients. I think it speaks to the demographic and just the epidemiology of where cases are residing, and we're going to spend some time talking about it. But here's, I think, something you need to note. These 3 hospitals together, we're at about 16,000 tests out of 50,000 tests. So we're at the other 34,000 tests. Those are the OptumServe sites. They're the Planned Parenthood site at Monterey Peninsula College, certain pop-up testing sites that are really designed for testing asymptomatic individuals who are concerned, who may have been exposed in a household or at a workplace. But you can see that that for the most part, when people present to the hospital symptomatic, the testing, the positivity rate is greater. And obviously the overall county rate is a blend of what we see at the hospitals and at the individual test sites. All right, so as testing has been performed, I want to point out that the vast majority of positive tests are occurring in young people. And you've read that, and that's the workforce, and whether that's the ag workforce, for sure, or any other service workforce, this is the heart of our workforce, whether you're in hospitality, whether you're in retail, whether you're in manufacturing, whether you're in ag. Generally, our workforce sits down here. And when people get infected out in the community, they bring it home. But for the most part, we see that people over the age of 50, 55 and over comprise 15% of all positives here in Monterey County. However, when you look at hospitalization by age group, 42% of all admissions occur in people 55 and older. So the risk of hospitalization increases with age and also with risk factors like hypertension, diabetes, and other comorbidities. So here at Community Hospital, again, a smaller test cohort, 17% of all tests positive tests occur in people who are over the age of 65. So 17% of the people that we test that have positives are over the age of 65. 24% of all admissions are over the age of 65. And if you test positive and are over the age of 65, about 68% of those particular patients end up being admitted to the hospital, about 2/3. Often they're well when we see them in the testing, in our test tent. We'll send off a test. They're mildly symptomatic. We will not admit them. But over the age of 65, that disease may progress. The clinical course may progress, and they'll be back at the hospital 3, 4, 5, 6 days later and require admission for more intensive therapies. So let's keep it simple. The numbers can be a bit confusing. We've gone through a lot of numbers. So I think it's important to have walking around numbers. So the first one is 1 in 10. 1 in 10. For every positive test that we've identified somewhere in the county, we clearly are not testing everyone in the county, and everyone is not coming for a test who may have COVID. Many people may be asymptomatic. Many people may have mild symptoms. Many people may find the access for testing is just too cumbersome. Many people don't want to get tested because of the impact it may have on their work status. So we believe that for every positive test that we document in the county, that represents somewhere around 10 people who actually have COVID or who have had COVID. So we're right now, if we're around 5,000 or 4,900 people who have documented test positives, that could mean as many as 49,000 or 10% of our population, roughly, 12%, 14%, actually would have if we tested everyone tomorrow, could possibly have a test or have had tests. Now, of those who test positive, right now around 5,000, about 1 in 10 require hospitalization. So if we've had 4,900 positive tests, we've had about 490 admissions to our hospitals across Monterey County. And if you're admitted to a hospital, you have about we've seen about 1 in 15 of our inpatients succumb to COVID-19. Simply the therapies, underlying comorbidities, severity of the illness become overwhelming. And so about 1 in 15 hospitalized patients die. Actually, over time, that has gotten better, and we'll talk a little bit about the therapies and how the therapies have improved our outcomes. So testing has been a source, I think, of a lot of confusion and frustration. Probably in the first 2 months, I got a call every day. Where can I get a test? I feel fine. I just want a test. Where can I get a test? My son-in-law was positive, and I saw him a week ago. I need a test. And I think it's important for us to first, let's talk a little bit about what different type of tests there are, what their significance are, when we should get them, where we should get them, and the like. Okay, so first of all, the test that you see people getting swabbed, you see pictures of drive-thrus. These are typically, drive-thrus in larger cities are not people who are asymptomatic. These are people who have appointments, who've been sent there by either some form of a healthcare provider, either a telemedicine provider or a provider or a physician of one sort or another. But the test is a PCR viral test. The virus is essentially a 100-micron low capsule, and it contains code. That code is in the form of RNA. That code is just like computer code. It's just like a virus in your computer. It infects cells in your body, and it hijacks the manufacturing process in your cells, and all it does is produce more virus, more code. So what we're testing for is that RNA code that sits inside the virus. It's called a PCR assay. It can take several days for someone to turn positive. Spent the weekend with my kids. My kids subsequently tested positive. It's Monday. I need to go get a test. Probably not. Yeah, typically 3 or 4 days after exposure is when people start to convert, where we have virus present enough to be able to actually turn it positive. There are lots of places where specimens are obtained, but the bottleneck in this pandemic has not been predominantly in the specimen, obtaining the specimen, but rather in where that specimen is run, where we have the lab equipment and the testing reagents in order to actually run that assay. Every hospital has at least one testing platform, and there are many companies that do testing. There's Abbott, there's Cepheid, there's DiaSorin, there's any number of laboratory equipment and companies. We all have those pieces of equipment. It's like having a copy machine, but not having the cartridges, the toner, in order to actually produce copies. We have the machines, but we have very limited supplies at our hospitals because of the national and international demand for the testing reagents. In fact, I can never recall a time when we actually were competing with the federal government for testing reagents. So we've, on more than one occasion, had orders in, and we've heard, well, we have to cut back on that order. It's going to be delayed because the feds won. So it's so the hospitals have testing reagents of limited quantity. The county has done actually yeoman's job, really excellent work in building up and scaling their testing lab, and they were the first in the county to be able to offer testing for COVID-19 and continue to grow their capacity to do between 500, maybe up to 700 or 800 tests a day now. Historically, just about hitting about 500, but maybe with additional personnel, may be able to get up to about 800. Now, if I swab a patient who has a positive COVID and is symptomatic, they can recover. They get better. 10 days later, after their symptoms have resolved, they have no fever. If you send that person, maybe that's one of your employees, you send them back 3 weeks later for a swab, 3 weeks after their symptoms first arrived, or maybe even 2 or 3 weeks after their symptoms have resolved, there is a reasonable chance that if we swab that individual, that there will still be evidence of virus in their nose. It does not speak to whether they are contagious, and in fact, proof of cure, negative swab testing for return to work is not recommended, and in fact, it is confounding. Why? Again, what we're testing for is fragments of virus, and that virus, when we assay it, we're not growing the virus, we're just looking for little fragments, like you're looking for a little fragment of code. Doesn't speak to the viability of those viruses. And just recall, when we've had, all of us have had employees with influenza. Does anyone ever remember sending your influenza patients, employees back for a negative influenza swab or test 3 weeks after they've recovered, or 2 weeks after they've recovered from their influenza? So it's become a practice. It was, I think, recommended early on, and it was, I think, it was promoted by industry. No one in healthcare believes that we should be doing proof of cure negative swabs before people return to work. There are other kinds of tests. There's a test called Quidel that you may have read about. Rather than looking for the virus itself, this is actually measuring those spikes that you've seen on all those representations of coronavirus, that protein. It's measuring the protein antigen that lives on the outside of the virus. So it's an assay for that unique protein. These are sort of what we call point-of-care test platforms. So we've launched them for our respiratory patients who are being treated or seen by our doctors at Montage Medical Group, and Doctors on Duty also has this testing platform. So if someone's symptomatic and they don't feel sick enough to go to the hospital, if they went to a Doctors on Duty, or if they're a patient at Montage Medical Group, they can have a Quidel test that is not necessarily the gold standard, but very good at assessing whether someone has COVID-19. And then there's what are called so-called serology or antibody tests. When we get infected, we develop antibodies in response to that infection. And this is really assessing for the development of antibodies. Typically 4 to 6 weeks after the onset of infection is when we'll measure, when we could measure. This has very little clinical significance today. There's not a lot of value in saying, well, am I immune? Do I have antibodies today? But what's important about these antibodies is they have been the source for therapy, so-called convalescent plasma, where patients who have antibodies, if they're healthy and they're able to, there are various opportunities and venues to be able to donate that plasma, and that plasma then is produced and it can be provided as a therapy. And we'll talk about that under the therapies as well. So testing the CHOMP, who do we test at CHOMP? Essentially 3 populations today. So when we see people here, we are not an asymptomatic community screening site. Our primary role, our purpose for being here is really to provide health care. So when we see people who are symptomatic presenting to our emergency room, we, in our triage tent, will swab them, and depending on their clinical presentation, we'll either run that test in-house, but again, very constrained quantities of that testing material reagents in-house, or we'll send it out to the county. We also do screening for patients if they're scheduled to come in for procedures. So if you're scheduled to have a hip replacement here or some form of GI surgery, we will test you. We will also acutely test. We will test you electively 3 days before your scheduled procedure. But then we see acute patients presenting, heart attack patients, labor and delivery patients. Those patients also get tested for a variety of reasons. Certain medical conditions are associated with more aerosolization, and we really need to know whether they are COVID positive. And then we have also, we obviously test our own staff, either asymptomatic. We completed a study a couple months ago where we swabbed 500 of our own staff. Those tests were sent off to another lab, but only one out of those 500 frontline staff members had an asymptomatic positive test. I suspect that would be a little different now. We've actually encountered, just as we are members of the community and as the prevalence of COVID has increased in our community, we've had our own personnel contract COVID as well. Generally out in the community, we believe that there's perhaps one staff-to-staff transmission here, a community-acquired case that then was transmitted to a coworker. We do not have any documented patient-to-staff transmission here at Community Hospital at this point. We do when we have employees, just like when you have employees, if they have had a significant exposure to someone with who is ill with COVID, we will quarantine those employees. And today we have about 30 employees who are not at work who are quarantined. Many of those employees get tested, but again, a test is a snapshot in time, and we could test you today, it would be negative, and it could be positive tomorrow. So we require those employees to stay in quarantine. And then finally, I think that's it for testing in John. Testing at other venues. Here on the peninsula, Planned Parenthood of Marmonte has been operating a testing site at Monterey Peninsula College. First come, first serve. Several days a week. No appointment necessary. Got to bring your ID card. This is for asymptomatic patients. The VNA, the County of Monterey with the 4 hospitals, Lee Memorial, Natividad, Salinas Valley, and Chomp, we all basically have pooled our resources and are underwriting the VNA to perform pop-up testing. They spent a week in Castroville. They're supposed to be in Seaside next to essentially, again, provide community screening. The problem with community screening is not whether you can actually stand in a car line and get the swab. The issue that we have encountered here in Monterey and indeed throughout Northern California and more broadly is once that swab is sent off, it can take 5, 10, 12 days to get a result. Knowing 12 days from now that you were positive 12 days ago is not very helpful because you've either been in quarantine or you haven't. And the other value of identifying cases is to allow the county to do contact tracing. It's simply impossible to do effective contact tracing 12 days after a swab was collected. In those 12 days, you may have come in contact with 100, 200 people, or hopefully this is someone who had cause and concern and was isolating. But the value of community screening is only, what we like to see intensive testing and screening in sites where there's been an outbreak, at a skilled nursing facility, at another another site of cohabitation, where we can get the results back in real time. So community testing is of limited value today. Turnaround time is the major issue. So when we first started seeing patients in March with COVID-19, our biggest shortfall, our biggest concern was we had no specific therapies that we could offer. There was some early initial promise and hype around hydroxychloroquine, around hydroxychloroquine, a rheumatoid arthritis drug, and with or without Zithromax. And so early on, we had a handful of patients who were treated with hydroxychloroquine. Notwithstanding the political battle that has sprung up around this, it's pretty clear that bona fide scientists, that up to five now large randomized clinical controls have demonstrated absolutely no efficacy of hydroxychloroquine. It's not a drug in our armamentarium. We do not use it. But three different types of therapies are in our armamentarium beyond just obviously high flow oxygen, supportive therapies, IV hydration, fever control, and the like. We're using low dose dexamethasone, which has been proven to reduce the severity, shorten the length of hospitalizations, and reduce mortality, and remdesivir, which is an antiviral agent manufactured by Gilead. Initially, remdesivir, the government essentially sucked up all of the remdesivir and allocated it out to states, and states in turn allocated it out to counties, and counties in turn allocated it out to hospitals. And that first bolus of remdesivir that we received was free. This company manufactures the drug. They spent a lot of time and money developing the drug. They now are selling the drug at what is, I think, arguably reasonable price for the medication. Again, it's on allocation. So our county gets an allocation. And this is an example where the 4 hospitals work together. We have developed a protocol where, and essentially a process where the 4 hospitals access the remdesivir using an agreed upon methodology and agreed upon indication. So one hospital is not sucking up all the remdesivir. We collaborate on this on a regular basis. And also convalescent plasma. Convalescent plasma is essentially taking the plasma of a patient who has had COVID-19, contains antibodies, and infusing that back. The data is getting better, and I think yesterday the feds announced that the FDA has approved it as a therapy. We've been using it as an off-label therapy in patients who are not doing well exclusively on remdesivir and dexamethasone. But there's a little bit more to it than essentially sticking a tube in the patient who's had COVID and drawing that plasma out. There's a process that's involved. So to date, we've talked about infection prevention. So the 4 essentials of an effective response: infection prevention, masks, hand hygiene, social distancing. And I wrote here the role of enforcement. Having rules for people to wear masks when people choose not to, it's not effective. We have signs posted. I live in Skyline Forest, and it says, I think it says 25 miles an hour. Maybe it says 35 miles an hour. But if I drive 45 miles an hour, 50 miles an hour, I know I'm going to get a ticket. Or just the fear of getting the ticket, the specter of getting the ticket, helps to really have me abide by what is the social contract. We need that, and kudos to our law enforcement agencies that are actively and actually assisting us with enforcement of the mask mandates. Contact tracing is an important element. I think the county's really done a nice job of ramping up. Frankly, as we get to a broad community spread, it's harder for contact tracing to do its job. It works much better in a confined space or in a workplace space. Testing, we've talked about the importance of testing, most important, accessible, but also timely results, and treatment we've talked about as well. This is a summary slide. So I know you've had access to, and we've had this discussion before, but I want to talk a little bit about if you have an employee who calls you and says, I got tested this weekend and I'm positive, and I was at work last week. And what is when can that person return back to work? So let's go through it. There are 4 criteria for someone to return back to work. There should be at least 10 days have passed since the onset of symptoms. 24, and if there were no onset of symptoms and the person just simply had a test, there should be 10 days that have passed since that test was positive. 24 hours fever-free without the use of Tylenol or aspirin or any other fever-lowering agents. They should have no symptoms. They shouldn't be actively coughing, and no return to work testing is required. If you have someone who is positive, what about those coworkers? So if you've had a positive worker in your workforce and they work closely with other people, what happens to those other coworkers? First of all, do we have to quarantine people if they worked with someone a week ago or 2 weeks ago? The criteria is if your infected coworker is around other coworkers up to 2 days before they became symptomatic or before their diagnosis. So your index case gets sick on a Monday, but works Monday and Tuesday, and then notifies you. People who worked with that coworker on Saturday, Sunday, Monday, or Tuesday need to be 2 days before the onset of symptoms, need to be quarantined. But if someone worked with them a week prior to the onset of symptoms, that person, and that was the last time they worked together, that person does not need to be quarantined. What characterizes an exposure? Greater than 15 minutes, working less than 6 feet apart. Does the presence or absence of a mask matter during those exposures? We believe that masks reduce the likelihood of infection, but they are not used in the decision as to whether someone needs to be quarantined or not. We know that sometimes masks are poorly fitted. People take them off when they have lunch together. There are issues around using masks as sort of a decision point or branch point in whether you're going to quarantine someone or not. I think it's important to note operate in environments that are either noisy or cold. So, meat packing plants, manufacturing plants, people yell. They generate more aerosol when they're speaking more loudly. Also, hence, with some of the some choirs and some church choirs where people are singing, it increases the risk of aerosolization. So there's a certain irony here. While someone who's infected needs 10 days on the bench and out of work, someone who's exposed actually needs 14 days in quarantine. So what's the value of testing someone who's been exposed? It's all about, are they symptomatic or not, and what will a negative test do? If you test someone 3 days after they've been exposed and it's negative, should you allow that coworker to come back to work? The answer is no. They still need to be quarantined for 14 days. So the testing is really, I recommend if people have symptoms, come up to the hospital and get tested. If they have no symptoms, first and foremost, they need to quarantine. And if they are going to get a test, wait a while. So masks are important. There are more and more articles that demonstrate the efficacy of masks. Even even as recently as in the Journal of the American Medical Association, Mass General, one of the iconic healthcare institutions, was able to demonstrate the epidemiology, how they markedly reduced healthcare worker infection by simply having everyone wear a surgical mask. So all masks are not created equal. We know that everyone loves their N95 mask. It's kind of the gold standard in some of your industries and construction and the like. In some of the trades, people have N95 masks. We know N95 masks are no more effective if persons haven't been fit tested, and if it's not, a high quality N95 mask where we've demonstrated through fit testing that it works. In our healthcare setting, it's the minority of our staff that we have in N95 masks. People who are working in direct patient care settings where there's potential aerosolization. So we have our ER in N95 masks, we have our COVID unit, our ICU and N95 masks and the like. The vast majority of our staff is in surgical masks. It works. The concept behind a mask is again, to try to prevent me from infecting you when I wear a mask. And when you're with no mask, I can infect you and you can infect me. If I'm wearing a mask, I'm not going to infect you, but you can still infect me. If we're both wearing a mask, we're markedly reducing aerosolization in both directions. It's, in fact, a social contract. So a fabric mask is quite effective at reducing aerosolization, as are, bandanas to a lesser extent. I think it's important for us to realize that regular diseases do not take a vacation during a pandemic. So we still have patients who have heart attacks, who have strokes, who have cancer, who need treatment. So we continue to be busy with those particular disorders. But we were really concerned and continue to be concerned by the fact that the number of strokes and heart attacks and serious presentations that we've seen typically has actually dropped. And so we've seen examples of people staying at home with all of those disorders out of fear of coming to the hospital, coming to the emergency room, out of fear of contracting COVID. It's really important to recognize that we have policies and procedures, we have protocols in place to ensure that patients, when they come to the hospital with non-respiratory, non-COVID illnesses, are safe, they're isolated, and they will not contract COVID as a result of coming here for their heart attack. So we're open for business for those things that people actually need ER care for, and I want to encourage you to not defer needed treatment out of fear for COVID. By the way, if you come in our hospital today, every single one of our inpatients, if you're a hospitalized patient, you're wearing a mask. Every one member of the staff wearing a mask. If you're a visitor, seeing someone who's here for end-of-life care, or a spouse or partner who's having a baby, you're wearing a mask. We screen everyone, and we work diligently to keep community hospital a safe place for care. We, along with other hospitals, have tried to be a resource for various businesses in our community. Hospitality, agriculture, education, retail, assisted living are just examples of areas. We consult nurses out in the fields, along with the other hospitals, at the request of different ag companies to provide education and assessment. We also have the benefit, and really, we're so lucky to have Dr. Geraldine Kaplan, who's an expert a specialist in infectious disease, present on our team. We provide her as a free resource to businesses in our community. If you're wanting to have your setup looked at, or if you're having specific questions on some of the things that I've just talked about, Dr. Kaplan is a resource. And how do you reach Dr. Kaplan? You go through our employer liaison, Jean Fisher, at 831-658-3983. I would be remiss to hold any presentation without recognizing our phenomenal staff. We have a staff of dedicated, courageous healthcare workers, whether it's nurses, physicians, pharmacists, respiratory therapists, nurses' aides, environmental service workers, food service workers. Every day they get up, they kiss their kids goodbye, they head off to work, they mask up, they glove up, and they care for our patients. And they've been an amazing team, and every day they inspire me, and I know that they've inspired many of you. We've been so fortunate and gratified and buoyed by the initial outpouring of support and appreciation and love that our team has received from members in our community, whether it's food or flowers or cards or letters or posters. On behalf of our entire team, I want to thank you for those expressions of appreciation. So I think it's fair to say as we're heading into the 6th month of this pandemic, some of that initial adrenaline rush that all healthcare workers felt and experienced has faded as we all come to the realization that COVID, this pandemic, is going to be with us for many more months to come. So something of a COVID hangover, a little bit of that rush is gone. We continue to press forward. We appreciate all that you are doing for us, and frankly, you helped us a great deal through the initial days of uncertainty and fear, and appreciate that so much. So I'm going to wrap up right here. I'm going to do a time check. It looks like we have, Frank, it looks like we have maybe, what do you think, 10 minutes?
Yes, we do. Thank you very much, Steve. We have a few questions that were submitted prior to your presentation. And I'm going to start with one here. That is this. Is there anything that you're seeing that gives you a sense of optimism? And what is the chief concern that keeps you up at night looking to the next 30 days?
Yeah, I think the thing that gives me a sense of optimism and the thing that gives me concern, they're both, one answer is they're related. The two things that give me optimism, one are evolving, three things give me optimism. One is evolving treatment modalities. You know, today we have an antiviral, we have dexamethasone, we have convalescent plasma. I think we're going to see what I'll describe as super antibodies, but pharmaceutical antibodies coming out in the not too distant future, meaning we know that certain antibodies work better than others. When we know what they are, pharmaceutical companies can actually clone them, they can grow them, they can produce them in a petri dish. And I think we'll see more therapies coming out in the next 60 days or so. The two other sources of optimism is the support that we receive from our community and the sense that people get it. No one likes closing their business. No one likes the space and the place we are in now. But I believe that there's a solidarity in our community, that people will continue to try to move forward with commerce, but do so in a way that is safe and that will hold each other accountable. This is not kind of, I don't think we're in a place where we should just say, well, I choose to wear a mask, but the person who comes in my store chooses not to, and I don't want to say anything about it. I'm not sensing that in our community. I'm having a sense that everyone recognizes the only way that we can be safe and that commerce can continue to resume is by all of us being part of our, being, if you will, kind of public health officers. The third thing that gives me optimism is my staff. We have a phenomenal staff. And as I said, I think they continue to do just a great job every single day. What keeps me awake at night is how many staff we have, and just the fact that with distance learning taking place, what's the impact of distance learning going to be on people's ability to continue to come to work? I worry about areas of particularly high resource utilization in terms of staff, our intensive care units, our operating rooms, and you know, even pre-COVID, we had staff, just enough staff. We didn't have a lot of extra staff. And with the various things that are happening now, for a variety of reasons, some people, their health doesn't allow them to come to work. They've got kids that have to stay at home. So I worry about staff. The other things that keep me awake at night are, frankly, on a daily basis, our supply chain team works to ensure that we have adequate number of N95 masks and other PPE that will serve us, you know, 2 weeks from now and 3 weeks from now. We really like to see, a runway of several weeks of supplies, and we're down in typically sometimes days on hand of 15 days or 20 days of certain things, and that does not make me feel good because we can have an increase in consumption. And the third is obviously testing. The third thing that keeps me awake at night. You know, this still remains a sore point for us. We know everyone wants more tests. We know we'd like to have more resources to be able to test much more on-site with rapid turnaround, rather than having you know, the bulk of community testing taking place out in commercial labs that have just been inundated. They're doing their best, but they're just basically getting testing from all sorts of sources, including, you know, the state mandate is that skilled nursing facilities must test every resident, every staff member every month. Every resident, every staff member every month. That's a huge bolus of testing that needs to be performed.
Thank you very much. There is another question here that just came in. And what are your thoughts about the schools reopening?
Well, I don't think that I know more than public health experts at the state and public health experts nationally on this. I find that every time we have chosen, for a variety of reasons in states or in counties or in cities, to ignore conservative public health advice in this pandemic, we've done so at our own peril, and we've paid the price. And we see this happening now in the Midwest, certainly saw it in the Southeast. Look, kids generally, other than a very unusual vasculitis that occurs in children that can be fatal, kids generally manage COVID infection very well, but they come home, and you know, we have a rich community here in terms of culturally. We have lots of multi-generational families. They come home and they see their parents, they see their nanas, their grandparent, their grandfather, and you know, we unfortunately have seen multi-generation transmission of COVID in our, you know, in our community. We've cared for people where that has been the mode of transmission. So, you know, do I believe that a 6-year-old is going to go to school, or a 7-year-old, and is going to wear a mask and is not going to play, and that there's going to be social distancing? I think the answer is no. I don't believe that. The right answer is hell no. I don't believe that. But frankly, so I believe at this point in time, unfortunately, distance learning is the safe way to go. I would say this: people are getting better at it. I've been on the phone with Janine Gus and PK Diffenbach. They are, you know, addressing this crisis head on. They're developing resources, plans, and policies to be able to ensure that kids get, you know, the kind of education that we all want them to have. It's not as good as an in-person education, but unfortunately, it's, I think, what we need to do right now.
Thank you. Quick one also that we receive sometimes here at the chamber on the phone is saying it's okay to wear a mask, and we understand it, but what about when you're exercising or running or bicycling? What is your recommendation?
I don't really think there's good science on this. You know, I think I do all of the above. I don't run as much as I used to, but I certainly walk and I bike, and I don't wear a mask when I'm biking. But the problem is, of course, then I stop and, you know, I'm at a light and there are other people there and I'm breathing quick. You know, I'm exhaling at a rapid rate, and I'm putting a lot of stuff out in that little cloud that I generate. So I think it's just one of those things. You know, I like to just wear a bandana that I pull up when I find myself, you know, stopped. I've seen people out on golf courses, you know, PG Muni and Poppy Hills and Bayonet, and people aren't wearing masks, and I think that's fine as long as, you know, when you walk into the pro shop and the like, you need to have a mask on.
And then one more here, Steve. There is a lot of concern about pockets of positivity in certain areas of the county. What is your preferred metric to use regarding positivity rates in the county?
Well, you know, we all follow some media where we say, oh, well, this zip code, no one who lives in this zip code, the incidence has been lower. Look, as I've said before, and I'll say it again, you know, this virus traveled 6,500 miles from Wuhan to California. It can certainly travel 14 miles from Salinas to Monterey. You know, we work and we live all across the county. We interact with people from the Bay Area when they come down here on the weekends. So the general kind of precautions that everyone needs to take, we can't have a double standard. We have to recognize at the same time that certain industries in certain areas have a higher incidence. So, you know, ag was an early industry leader in terms of the number of cases that we saw in Monterey County. It's a reflection of, I think, you know, congregate living. We have a migrant workforce that comes to the area. They're living together. One person gets infected, they infect others, and in the workplace. I think ag's been working really hard at ensuring that there is no transmission of COVID in the workplace or in a worker provided or an employer provided transportation to the fields. But what happens at home, whether that's in an apartment or other form of housing, is more difficult, more challenging. So, you know, I think, you know, the Willie Sutton rule is you go where the money is. You figure out where there are greater incidents or greater pockets, and you intensify your efforts at prevention, hence the education that we've been trying to provide as an industry to a very important other industry in our community, ag, and and close second, hospitality, obviously.
Okay, well, thank you very, very much, Steve, for a very informative presentation this morning and for submitting your very good questions to us. Thank you again, and thank you to the staff at the Community Hospital, Montage Health, and we really appreciate your partnership. I'm going to take just a moment. I'm going to take just a moment to mention that we have a leadership luncheon that is coming up. You remember we do this every year in September. We invite all of the elected officials to a panel. This will be virtual again, and we have secured the date of August 24th, which is Monday, to hold our next leadership luncheon. So you will receive a lot of information about it in the next few days. That being said, I appreciate your attendance this morning. Thank you for supporting the chamber, and thank you for participating in our quarterly CEO breakfast. Have a good day. Thank you.